Good afternoon. My name is David Baum, and I'm a member of the Board of Directors of Parkinson Social Network. We'd like to thank you for joining us this afternoon. Today's presentation is entitled, "Why is it so hard to get a good night's sleep with Parkinson's disease?" For those of you who have not joined us before, we just wanted to remind everyone that Parkinson Social Network is an all-volunteer organization that was founded by people who have a personal interest in Parkinson's disease, either as being a person with Parkinson's disease or being a care partner. Our mission is to support, advocate, educate, and enrich the lives of those who are touched by Parkinson's disease. In order to achieve our mission, we offer some online resources through our website and through our YouTube channel. We host virtual events such as today's, and we provide telephone assistance. Our webpage is www.parkinsonsocialnetwork.org. Our phone number is 571-286-5000, and our email address is info@parkinsonsocialnetwork.org. I want to review some housekeeping points. Because today's presentation is being recorded, we have muted everyone and asked all of you to remain muted at all times throughout the presentation. If you have any questions, please use the chat feature of Zoom. The questions will be accumulated and provided to our presenter for response during the designated breaks. Today's presentation is being recorded and will be available on the YouTube channel. Also, should anyone need a hard copy of Dr. Stein's slides, send an email to us and a copy will be made available. Today's presenter is Dr. Lawrence M. Stein, who has over 40 years experience serving patients, is the senior partner in PMA Health. He is board certified in sleep medicine, pulmonary disease, critical care medicine, and internal medicine. He serves as the medical director of the sleep lab at VHC Health in Arlington, Virginia. And now I am going to turn you over to Dr. Stein.
So first of all, thank you for inviting me today. I wanted to give an overview of the issues with sleep in Parkinson's disease because it is quite extensive and I probably won't be all inclusive, but I'll try to touch on a lot of topics that are important. And I'll try to put them into some characterization of why they're important. Next slide, please. Okay. So we're going to talk a little about, briefly, what is normal sleep in adults, and then we're going to talk about how Parkinson's disease is different. Most people require 7 or 8 hours of sleep a night. The best sleep is continuous sleep. They've done multiple studies on that, so that if you get 2 hours sleep 4 times a day, it's never as restful as a long block of sleep. Sleep requires both mental relaxation as well as motor relaxation. So you have to relax your muscles and your mind to go to sleep. Once you enter sleep, sleep is a complex structure that has multiple stages of lighter sleep, deeper sleep, and dream sleep. And we go through cycles every 90 to 120 minutes. So we usually have about 3 to 4 cycles of sleep during our sleep period. Dream sleep or REM sleep is usually predominates later in your sleep night, and it's characterized by both irregular shallow breathing, the processing of memories, and also usual decreased tone, or what we call atonia of muscles. That's important because we're going to talk about REM behavior disorder later, which is an abnormality of typical dream sleep. Typical dream sleep, you don't move any skeletal muscles at all. You only move smooth muscles like your diaphragm and some other voluntary muscles. Next slide. The reason sleep is important is that it's important in human physiology as a restorative role. It helps us rest, get ready for the next day, but allows our organs to rest. And usually when we get a decent night's sleep, we're able to tolerate medications better, and we're able to tolerate our medical problems better. Sleep is also important in storing memories. And if you disrupt sleep enough, you can end up with daytime sleepiness. Next slide. Parkinson's disease, as you know, is a motor disorder characterized by low dopamine levels in the basal ganglion of your brain and the thalamus of your brain. It results in resting tremor, limbs, and head, and also has motor stiffness with prolonged muscle contraction. It results in poor coordination and balance, leading to falls, and there's a slowness or bradykinesia of initiating movement. So one of the issues with Parkinson's disease and sleep has to do with the motor component. So that if people are not properly treated for the Parkinson's disease when they're sleeping at night, they can get different changes in tone of their muscles, profound stiffness and rigidity of their muscles, muscle cramping, and difficulty shifting in bed. And that can result in uncomfortable sleep, frequent awakenings, and also pain, which also wakes people up from sleep. So there's certainly motor issues that can worsen as you progress in Parkinson's disease that makes your quality of sleep worse. Next slide. Besides the motor issues that are complications of Parkinson's disease also has non-motor issues, non-motor manifestations of disease. One of the principal manifestations is autonomic dysfunction, which can cause swallowing issues, sweating, lightheadedness, but also can cause urinary dysfunction. There's quite a lot of information that there can be hyperreflexia of the bladder muscle, which is called the detrusor muscle, and that can cause overflow incontinence and overactive bladder syndrome. That leads to a lot of urination overnight, which can disrupt your sleep, as well as the motor activity. There was a question that someone asked about getting up in the middle of the night about 3 in the morning and having to urinate a lot. This could be the reason for that. It's a part of the disease. It can be from autonomic dysfunction. Obviously, there's other reasons people urinate overnight. They can urinate because of an enlarged prostate. They can urinate because they have diuretic therapy, diabetes that's poorly controlled, heart failure. So there's multiple other medical issues. But from Parkinson's standpoint alone, you can get nocturia or urination overnight. There's also emotional issues or lability that can occur with Parkinson's disease, which can lead to depression, anxiety. You can get constipation, fatigue during the day because of the muscle issues, and also insomnia. And we're going to go through insomnia in a few minutes. Next slide. Because of the nature of Parkinson's disease, sleep can be very disrupted, both from the autonomic dysfunction of the disease, as well as the motor component of the disease, and 40 to 45% of patients experience insomnia. Daytime fatigue can be from poor quality sleep, but it can also be because of other components in terms of use of medications, and also because there's a neurodegenerative component to Parkinson's disease that can disrupt the day-night cycle, as well as lead to dementia. And we'll get to that in a minute. There are prolonged muscle contractions and stiffness that can make it hard for you to relax and initiate or maintain sleep, which we talked about. Remember, that can also be from an off phenomena where the medicines that are taken during the day wear off at night, and therefore are good for daytime symptoms, but do not control nighttime symptoms. And again, both the motor component and the other complications of Parkinson's disease can lead to a lot of disruption of sleep. Next slide. So I list this slide only because besides the motor component and the non-motor complications of Parkinson's disease, as well as the neurodegenerative component of Parkinson's disease, which can lead to dementia and problems with the day-night cycle, the medication itself that you use to treat the Parkinson's disease can lead to fatigue and sleepiness. So if you look at dopamine agonists that many people use, the ropinirole, the pramipexole, the rotigotine or the Nupro transdermal patch, those can cause sleep attacks. Apomorphine can cause sleep attacks. Other drugs like amantadine can cause insomnia. Multiple monoamine inhibitors are associated with fatigue and can also cause or worsen insomnia. So many of these drugs can be associated with fatigue in and of themselves, including cinnamon. So like many other complex disease, some of the fatigue you feel during the day or the problems with insomnia that you have at night or the disrupted sleep you have at night, some of that could be from medications or it could be from the nature of the disease itself. And that's why it becomes complicated to try to figure out what sort of regimen that you need. Next slide. This slide has to do with some of the neurocognitive issues with Parkinson's disease. Like many of the neurodegenerative diseases, like multisystem atrophy, Parkinson's disease can be associated with dementia. Most people with Parkinson's disease have symptoms starting at 50 to 85, but you know that there are people like Michael J. Fox that had signs much earlier than that. There's also about 75% of patients that with Parkinson's disease after a period of time will go on and develop some type of dementia. And 30% have mild cognitive deficits within 5 years of the onset of the disease. And the last line is something we alluded to earlier, which is because it is a neurodegenerative component, there's a loss of the normal day-night cycle. It's similar to what happens in patients with dementia itself, where advanced dementia patients will tend to be awake at night and be sleepy during the day because they lose their day-night cycle. You can also get hallucinations that can develop in patients because of the neurodegenerative component of it, and that occurs in more advanced Parkinson's disease. Next slide. This is just a slide that has to do with sleep disorders that are increased in patients with Parkinson's disease. So again, we've talked about Parkinson's itself causing problems with sleep. The medications can causing problems with sleep, but there are certain sleep disorders that are associated with Parkinson's disease that occur with much higher frequency. Insomnia can occur in 45% of patients with Parkinson's disease. REM behavior disorder, which we're going to talk about in a few minutes, usually occurs in about 1% of the population, but occur in about 30% of patients with Parkinson's disease. Obstructive sleep apnea occurs in usually about 2 to 4% of the population, occur in 20 to 40% of people with Parkinson's. Restless leg, which usually is about 3 to 5% of the population, can occur in about 15% of patients with Parkinson's disease. So all of these conditions are significantly higher in patients with Parkinson's disease. Non-REM parasomnias is a little bit more of a confusing topic because it's not as well recorded, but somewhere around 2 to 5% of patients with Parkinson's disease can have what we typically get in kids: night terrors, confusional awakenings, and sleepwalking. It doesn't happen commonly, but it can happen. And nightmares can occur in about 70% of Parkinson's disease based on questionnaires, and that might be affected by medication as well. Next slide. So what causes these issues? And what causes the issues is progression of the disease, which occurs with time. The more of the progression, the more likely you get neurodegenerative changes and can cause sleep day-night cycle. This is a cat that's sleeping during the day, so he has disruption of his day-night cycle too. Next. Psychophysiologic insomnia is a condition which is a disorder of somatized tension and learned sleep preventing associations that results in the complaint of insomnia. The easier way to say that is, a lot of people, when they have problems during the day, they look at those problems, try to look at all angles and try to solve those problems. If you focus on your inability to sleep, if you try to solve your inability to sleep, you usually make it worse because you have to relax both your muscles and your mind to go to sleep. So a lot of people with chronic insomnia, when they focus on their inability to sleep, they create tension in their bedroom. They become frustrated with their inability to sleep, and they make the problem worse because they can't relax. Next slide. So we want to talk briefly about insomnia treatment. Now, we're going to talk somewhat about medications, but medications are a little problematic with Parkinson's disease because they're already on a bunch of medications and there are interactions with some of those medications, and we'll talk about that in a minute. So the things you want to do if you have Parkinson's disease is you'd like very much to reestablish a day-night cycle. You like to do regular exercise. You like to have better lighting during the day. You'd like to avoid daytime naps if possible. You'd like to have a blue light blocker for reading at night because blue light tends to stimulate people to stay awake. It's what they use in the, space stations to create daytime, nighttime. They'll use blue light during the day to create people being alert. You'd like to eliminate electronic devices 20 or 30 minutes before going to sleep. You'd like to write down what your issues are in terms of an agenda of the day to work through those issues and problems so you don't go into your bedroom with your mind racing. You sort of try to gain closure to your day. You try to eliminate any factors in your bedroom that cause disrupted sleep, like excessive light, noise, vibration, that can cause you to wake up because there's all these other reasons for you to wake up. And you try to use some sort of filtered noise, fan sounds to filter out everything else out so that if you can't go to sleep, you try to do some slow, deep breathing, relax, and focus on that sound so that you can go to sleep and relax. Next slide. There are medications that people can use. The most important thing, and this is true of the nocturia as well, is to try to plan on using some Parkinson's medications that work while sleeping, not just while you're awake. So a lot of people will use long-acting Sinemet in the evening to help with some of their muscle cramping, sort of get over the off phenomena. We have, stiffness and cramping. That's been shown to be helpful for those motor symptoms, but it hasn't really helped the quality of sleep. Often you'll need a combination of a dopamine agonist with the Sinemet or use of the monoamine inhibitors type B or the MAO inhibitors type B with the long-acting levodopa, carbidopa in order to help with sleep quality. There are other drugs that can be helpful with Parkinson's disease. Melatonin is very helpful because it reestablishes the day-night cycle. It sort of hopefully allows you to set such a cycle so that you don't have disrupted day-night cycle. Rosarum is a melatonin agonist. It seems to work similar to melatonin. It's a little more specific, but it isn't used quite as much. It's not as sedating. So some people prefer to use melatonin, but it does have a little bit more of an insomnia effect because it is more specific for the two melatonin receptors in your brain. Trazodone and doxepin are common drugs that people use with sleep disorders. It's listed at the end of the list because if you're on an MAO inhibitor, you can't use antidepressants. So it's less frequent that we use it in Parkinson's disease and other conditions. Benzodiazepine-like drugs, which are things like Zolpidem, which is Ambien, Lunesta, Sonata, can be used. But again, you have to be a little careful because you don't want to use anything that's long acting because you don't want to affect fatigue during the day. The nice thing about these drugs are they do have a little bit of muscle relaxation effects. Benzodiazepines have much more muscle relaxation effects. And so sometimes they are helpful if you use short-acting benzodiazepines to help with overnight relaxation and less muscle cramping, along with the additional Parkinson's medication. So it sort of depends on how severe the symptoms are. So again, there are non-pharmacologic and pharmacologic treatments that you can do for insomnia. The most important thing for Parkinson's disease is to make sure you treat the disease with medication overnight so you don't get an off phenomena and get muscle cramping, stiffness, and more autonomic dysfunction. Next slide. REM behavior disorder, as I said, is up to 30% of patients with Parkinson's disease because of the neurodegenerative quality of it. Cats really know how to do sleep. They rest all their skeletal muscles. They actually can take the shape of a chair or a couch, and much more than humans can. But REM behavior disorder is an abnormality of REM. Usually, even though you dream in REM sleep, you have no skeletal or almost no skeletal muscle tone. But in REM behavior disorder, you lose the REM skeletal muscle atonia. So you start actually acting out dreams, even though you're not aware of it. But there's reports of like jumping out of bed, kicking, punching, doing all sorts of dream enactment. And this raises a question about whether, there can be safety concerns. And that's the biggest issue with REM behavior disorder, because you can hit your bed partner or you can jump out of bed. We've had people that jump into dresser drawers and other objects in their bedroom. Next slide. So REM behavior disorder usually occurs in the 6th and 7th decade. It's much more common in men than women. It's associated with neurodegenerative disorders like Parkinson's disease, Lewy body dementia, multisystem atrophy. It can precede the onset of Parkinson's disease by 5 to 7 years. And it's and that's something we tell people that present with REM behavior disorder, and it can be precipitated by tricyclic antidepressant use, MAO inhibitor use. Remember, using an MAO inhibitor type B for Parkinson's disease, withdrawal from alcohol, sedative, and hypnotic agents. The reason alcohol and sedative hypnotic agents precipitate the disorder is because you get sleep disruption from alcohol, and you get an increased amount of REM sleep. And because you have a higher concentration of REM sleep, you have a higher chance of having REM behavior disorder during that period of time. Next slide. So again, you have to think about physical safeguards. You have to pad the floor near the bed. You have to place barriers on the side of the bed. Sometimes I tell people to sleep in sleeping bags or on weighted blankets, because they can't move as much. They can't swing their arms. You want to remove sharp objects from the bedroom because people can jump into dresser drawers. You want to move furniture and other objects away from the bed. And some people, what they do is they'll separate the two beds so the two bed partners are not quite next to each other. Or sometimes they'll sleep in separate bedrooms if it gets bad enough. Next slide. The treatment for REM behavior disorder, it can be melatonin. 5 to 15 milligrams of melatonin can greatly diminish it. Classically, REM behavior disorder is treated with clonazepam. It's a very effective treatment, but it has a very long half-life, about 30-hour half-life. So it's very hard to treat people that have daytime fatigue or sleepiness, which many people with Parkinson's do have, with a drug that causes sleepiness, okay, or fatigue during the day if you use it. So clonazepam is a very popular drug for REM behavior disorder, but not necessarily in this population. Pramipexole, which is a dopamine agonist, can be used. There's some evidence of it being effective. Some of the dementia medications like Aricept Exelon, which is transdermal rivastigmine, can be used. But the evidence beyond the first two is a little bit more patchy of how effective it is. Then there's some reports of benzodiazepines that are short-acting clonazepam, like temazepam being helpful, or Sonata being helpful. And there's even some reports that paroxetine, which is Paxil, could be helpful, which doesn't make a lot of sense since tricyclic antidepressants and SSRIs have been implicated in the onset of REM behavior disorder, like Lexapro has been implicated in the onset of REM behavior disorder. So you can see that because it's a relatively rarer disease, there isn't as much clear research on what drugs are most effective. And beyond the first two, some of them are more idiosyncratic with short, small trials of patients that it may be effective. Next slide. I don't want to spend a lot of time with other conditions, but I think it's important because these sleep disorders are so much more common in Parkinson's disease to talk about them a little bit. So obstructive sleep apnea is something I spend a lot of my day on. It's characterized by repetitive episodes of total or partial upper airway obstruction during the night that's associated with arousals or drops in oxygen. The site of obstruction in sleep apnea is not in your nose, so nasal surgery will not eliminate sleep apnea. It's behind your tongue or behind your pharynx, generally is what it has. And so people with large tongues like this ringmaster would be someone that would be a candidate for sleep apnea. Next slide. We describe sleep apnea by events, respiratory events that last at least 10 seconds, by something that has almost no airflow into your lungs despite effort, and that's called an apnea, or hypotneas, which have a 30 to 50% reduction in airflow associated with awakenings, or a 3 to 4% drop in oxygen. So these are pretty clear definitions. You're looking at airflow based on baseline values before they sleep, or right as they get to sleep. Next slide. We characterize sleep apnea on mild, moderate, or severe based on the number of events per hour. We consider less than 5 events being normal, less than 5 breathing events to be normal, 5 to 15 to be mild, 16 to 30 to be moderate. But it can be a little more complicated than that, because if you have, these are events are 10 seconds, but you could have people that have 30-second events. Those are not mild. So if you have, 30-second events, you're going to have less events per hour, but they're long events with big oxygen desaturations. That has to make the event to be much more severe than just mild, if you had 5 of them an hour that lasted 30 seconds. Next slide. Some of the symptoms of sleep apnea would be loud, irregular snoring, daytime sleepiness, which of course we talked about other reasons you can have daytime sleepiness in Parkinson's disease. You can throw your sheets off the bed because you're moving around a lot during the night. Your bed partner might say you stop breathing, which is always important, because I always like to say that, I do a sleep study one day of your life, but your spouse lives with your sleep every day of your life, or almost every day of your life. So the bed partner usually has a pretty good idea in most cases that there's a problem. Morning headache, dryness to your mouth, and multiple awakenings from sleep. Again, there are other disorders that can cause this. We talked about why you get multiple awakenings from sleep with Parkinson's disease, but sleep apnea will also cause that problem. Next slide. The reason we talk about sleep apnea is because it causes, last slide, it causes health complications. When you have a breathing event, which lasts 10 seconds, where you can't get enough air in or air out, you're delivering less oxygen to your organs. And so it's a stress state. And like most stress states in the body, we secrete adrenaline. Adrenaline takes you from a deeper, more refreshing level of sleep to a lighter level of sleep, where your breathing is better, but it's less refreshing. And those adrenaline surges are associated with elevations in heart rate and blood pressure. The blood pressure can change 50 or 100 points. After a while, you have a elevated adrenaline level all day long, and so you get daytime hypertension. It can be aggravated. You can also, if you have low oxygen and elevation in blood pressure, you can get pulmonary hypertension as well. Polycythemia is an elevation in your red blood cell count. Low oxygen stimulates your kidneys to produce erythropoietin, which is a hormone that produces more red blood cells. And so we have recurrent low oxygen at night. It can result in polycythemia. It's not a common problem with sleep apnea, but it can be a serious complication of sleep apnea. Insulin resistance can occur in people with sleep apnea. Epinephrine or norepinephrine are counter hormones to insulin. That is, they do the reverse of what insulin does. Insulin breaks down sugars and makes more sugar. They take sugar and put it into starch and stores it into your bloodstream. So insulin takes sugar out of your bloodstream, and norepinephrine does the opposite. It basically breaks up starches in your liver, produces more sugar that's in your bloodstream as part of the fight or flight reaction. Atherosclerosis, which can lead to heart attack and stroke, is something that occurs because of sleep apnea. It doesn't lead to sleep apnea. It's a atherosclerosis. It occurs because of sleep apnea, and it's because of that, it's a risk factor for heart attack, stroke, and heart failure. Cardiac arrhythmias, because the frequent adrenaline surges can occur with sleep apnea, such as atrial fibrillation. If you have atrial fibrillation and you don't treat your sleep apnea, this was worked out at Mayo Clinic, your chances of getting atrial fibrillation within the next year more than double. So you get another attack of atrial fibrillation, even if they get you out of atrial fibrillation. Next slide. This is a very old slide from 1988, and we don't characterize, we have apnea-hypopnea indexes. This is when they had apnea indexes because the equipment wasn't as good. And they cut off mild to moderate based on less than 20 or more than 20 events. The reason I show this slide is even though this was way back when in 1988, you can see that people that were characterized as mild, they have a little bit of mortality, but not a lot. But once you get above mild, they get to moderate to severe, there's significant increase in mortality that you can see. Cumulative survival rate markedly goes down as you go with interval a number of years, mostly cardiac related with moderate disease. Next slide. So there is a mortality related to sleep apnea. There's an increased chance of getting heart attacks and strokes, heart failure, arrhythmias. So the treatment options can be as simple as losing weight. You have about a 70% chance that your apnea-hypopnea index drops in half with a 10% drop in weight. It could be sleeping on your side, which can be a little bit difficult because you put a lot of stress on your hip joint or your shoulder joint when you're on your side. But there are certain pillows like called therapeutic body pillows that help you stay on your side because they put less stress on your shoulder and your hip joints. It could be CPAP, which is illustrated here. This is a new mask called the DreamWear mask, which are better than older masks because it only goes under your nose. It isn't claustrophobic, which acts as an air splint. It basically blows open the back of your throat so you breathe better, and your breathing is like it is during the day. That's what CPAP does. It just restores the space that's collapsed. The lower picture, by the way, is an Air Mini, which is a travel unit. And you can see that some of the units in CPAP are much, much smaller than they were in the past. Oral appliances fit your upper and lower teeth. They have a hinge or joint in. They move your lower jaw forward. They open up the back of your throat. They let you breathe better. They're mostly for milder disease. They work better in people that aren't overweight because when you're not overweight, the anterior posterior dimension of your airway is more important. With extra weight, you tend to get more circumferential collapse of your airway rather than anterior posterior collapse of your airway. Bongo, I didn't make the name up, is a nasal EPAP device. It's basically a one-way valve that goes in your nose, allows you to breathe air in, but gives you resistance to breathing air out and opens up your airway based on that retrospective pressure. Excite OSA is a new therapy. It's a neurostimulatory therapy. It's like a TENS unit to your tongue that stiffens your tongue, prevents it from falling back. And by doing that, it mitigates your snoring and helps your sleep apnea, usually about 50%. You use it over about 6 weeks, and then chronically, it makes your tongue the Arnold Schwarzenegger of tongues, so it doesn't move. And finally, surgical intervention, like the Inspire device, when they use it, they open up the back of your throat, or they move your tongue forward. And surgical intervention, the Inspire device is an implanted device that basically stimulates your tongue to move forward when you take a deep breath in, and you've seen the commercials, I'm sure. It is effective for moderate to severe disease, but it's only about 75, maybe 80% effective, as opposed to CPAP that eliminates 98% of events. So it's not quite as effective as CPAP, but it is effective for moderate to severe disease. Next slide. Restless leg syndrome. So restless leg syndrome is this incented desire to move your legs. I mean, you just want to move your legs. You have pins and needles sensation in your legs. You have a creepy crawly sensation in your legs. You're restless at night. The desire to move your legs really occurs when you're at rest and improves with activity, and it's much worse in the night. Next slide. It usually occurs in people over age 40. Caucasians are more affected. Women are about 1.5 to 2 times more affected than men. So sleep apnea is more common in men. REM behavior disorder is more common in men. Restless leg syndrome is much more common in women. And actually, insomnia is more common in women. Next slide. This is a slide on restless leg in the normal adult population. It's got 2 to 5% of the adult population. There's some familial component. As you know, in Parkinson's disease, you're talking about 15% of patients with Parkinson's disease. So at least 3 to 5 times more patients with Parkinson's disease have restless leg. It's associated with iron deficiency anemia. So that if you do blood tests and you're anemic, or your iron stores are low, that is, your serum ferritin is less than 50 to 75 nanograms per cc, per liter, essentially means that this will increase your risk of restless leg syndrome, and treating the iron deficiency markedly improves the restless leg symptoms. Lumbar radiculopathy can also cause significant issues because of problems with your legs. It can cause restless leg syndrome and cause pain. And then there's peripheral neuropathies from diabetes, from renal failure, from alcohol, that are also associated with restless leg syndrome and can cause worsening leg movements. Medications which aren't on this list, by the way, tricyclic antidepressants, anti-nauseant medications that suppress dopamine, like Phenergan, can cause it, and old-style antihistamines can cause restless leg symptoms, like Benadryl. Next slide. So what's the treatment? Well, there's lots of over-the-counter non-pharmacological methods of treating restless leg. People use warm baths at night. They do muscle rubs. They obviously can take iron supplements. But magnesium at night can cause muscle relaxation and can be helpful for restless leg syndrome. Quinine in tonic water can be helpful as well. It's something we used to do. People say it's got a lot of sugar in it, and so they don't like to take it, but otherwise it's very effective. Seizure medications like gabapentin, Lyrica can be very helpful for restless leg. The dopaminergic agents like Cinnamate or ropinirole or Maripix, which we use for Parkinson's disease, can be helpful for restless leg, but they can be associated with some augmentation. That is, instead of just having restless leg at night, it can occur during the day, and you can escalate the dose. So after a while, the dopaminergic drugs can be less effective in restless leg. That sort of augmentation does not occur with the gabapentin or Lyrica. Benzodiazepines like clonazepam can be very effective to help the restless leg. Again, clonazepam has a very long half-life. We don't use it that much. Narcotics like Percocet can be very helpful, but also has an addictive component. Can be particularly helpful for people with lumbar radiculopathy, and baclofen can also be helpful as a muscle relaxant. But may not be as effective as some of the other agents higher up on the list. Next slide. So what I tried to do today, and I didn't want to take up the whole hour because I know there are going to be questions. And I'm happy to answer some questions as best I can. But what I wanted to explain is that the reason there's a problem with sleep with Parkinson's disease is because there are multiple issues that cause sleep disruption related to Parkinson's disease, both the motor complications of muscle stiffness and spasm, of dystonia, or shift in tone, or a difficulty moving around at night because of discomfort when you're in bed from Parkinson's disease, the non-motor complications of Parkinson's disease, such as the autonomic dysfunction that leads to nocturia and sweating, the neurodegenerative part of Parkinson's disease can cause problems with your sleep-wake cycle, and then the medications themselves, which can cause fatigue and sometimes sleep attacks during the day. And then finally, unfortunately, in Parkinson's disease, there are some sleep disorders that we commonly treat that are much higher in incidence, be that insomnia, restless leg syndrome, REM behavior disorder, sleep apnea, as well as the non-REM and REM parasomnias like nightmares, sleepwalking, confusional arousals, etc. So I just want to put that in perspective for you. I didn't mean to confuse you, but I just wanted to show you how complex the issue is. And we haven't even talked about medical issues that can cause some of the same issues that some people with Parkinson's have, because as you get older, you accumulate medical problems as well as medication. All right, I'll open it up to questions.
Angela, you want to relay the questions from the chat?
Sure. Actually, David, I'm going to start with one that came in previous to Dr. Stein's presentation, which was how are patients with narcolepsy and sleep apnea affected? So it sounds like people with multiple, not just Parkinson's, but narcolepsy and sleep apnea.
So the sleep apnea I tried to touch on in this talk, it is higher in incidence. It's usually 2 to 4% of the population. Adult population is 20 to 40% of the adult population in patients with Parkinson's disease. And it's treated, pretty much the same way. Narcolepsy is much more complicated. Narcolepsy usually has a peak in the when people are in their teens to 20s, and maybe another peak around 50. Narcolepsy is just sleepiness, but it's a problem with the day-night cycle. There are so many reasons that you can have sleepiness and not have narcolepsy in Parkinson's disease, both because of medications and because of sleep disruption. So it becomes a harder issue. It also becomes a hard issue because stimulants, if you use stimulants, can sometimes cause some worsening of your ability to go to sleep, and can also worsen the restless leg syndrome to some degree. So it becomes a little more complicated whether you have narcolepsy or can diagnose narcolepsy at an advanced age of Parkinson's disease. If you carry the diagnosis of narcolepsy going forward, in other words, from an earlier age and then get Parkinson's disease, the treatment is usually something like modafinil or armodafinil or some stimulant. But again, that's complicated because there's so many medications with Parkinson's disease that can cause fatigue, can cause sleepiness. So you have to be careful in terms of selecting your medications. Next.
Thank you, Dr. Stein. The one in the first one in the chat was mirtazapine. Why would you use it, and when would you use it?
Okay. So mirtazapine is it's a antidepressant that has anti-anxiety effects and anti-pain effects. It is very helpful as a sleep aid. because it does have some anti-anxiety effects, and a lot of people that have insomnia or chronic insomnia can have a lot of frustration or anxiety or stress when they create stress when they go in their bedroom at night. We use it a lot for insomnia, but it does cause weight gain in some people, so it can be problematic, and some people don't like to use it for that reason. It also is complicated by what the same thing for doxepin or trazodone is. A lot of patients with Parkinson's disease use MAO type B inhibitors, and you can't use them together. So the answer to mirtazapine is it's a very good insomnia agent. It's very good for chronic insomnia, but it has some complications, and it's difficult to use in patients with Parkinson's disease. If they use MAO type B inhibitors, they can't use it. So I hope I answered the question, but go ahead.
I hope so too, Dr.
right.
Stein. We'll
right.
keep an eye on the chat. The next one was, how about CBD or even THC products? And do any of these help with sleep?
Okay. I guess that's a general question and not a Parkinson's question, but CBD is helpful for pain. So if people have pain, CBD can be helpful to help them sleep. And some people find it, helpful if they use it, some oil, or they rub it on their joints. And that can be fine. THC, although there's a lot of things written about it, I think that it's difficult to use because it's not as standardized. So one of the things that I know that there's certainly dispensaries that are used by the state, including the state of Virginia, but it's very difficult to get a formulation where the same dose is given all the time, or has been. I mean, maybe they're trying to correct that. And so, you can use THC, and one time it works great, and one time it doesn't work, and one time it puts you in a coma and ends up in hospital. So I'm not a big fan of THC for sleep. I don't think they've really standardized it very well. I do think it's problematic with people to use other medications because it is sedating, a little bit sedating, but it also is mood altering. So, and it can cause problems with focus, and it does have some safety issues related to it. I think CBD for people with pain can be very helpful, and I've used it, or, certainly told people they can use it, and some people have found it helpful.
The next question we have is, this person says, I slept much better on HRT, but was taken off years ago. Would estrogen therapy help at this late date?
With the sleep?
Yes.
Okay. So HRT does help a little bit with how you feel, reduces sweats, and it can help somewhat with sleep. The problem with HRT is increase of cancer, increase in breast cancer, uterine cancer, et cetera. So I think a lot of obstetrician gynecologists are a little bit negative about it. Also, HRT, by the way, helps with osteoporosis, or decreasing the chances of osteoporosis. But I think the cancer risk is what really pushes people to probably not use it for long periods of time, because of the significant risk of uterine cancer and breast cancer.
Got it. Thank you. One question is, how about do you suggest a banana before bedtime for the potassium?
Banana before bedtime. So the answer is no. I mean, I like bananas for potassium, and they're helpful. The issue with eating before bedtime is sometimes food lays on your stomach and you get acid reflux. And in those patients, they can get up or to get disrupted sleep, or violently wake up from sleep, and they don't even know they have a heartburn, because by the time they wake up, they are just aware they're up. Sometimes you'll get sweating from it. So it can be problematic eating before you go to sleep. I know there's some people that like milk before they go to sleep, and they take small quantities, and that's fine. But we are a little bit cautious about telling people they can eat before they go to sleep. The general rule for people with acid reflux, especially hiatal hernias, is not to eat for 2 hours before you go to sleep. and to try to prop yourself up or sleep a little bit reclined. And obviously there's medications for acid reflux as well that some people take, like famotidine.
Okay.
Yeah.
One of the questions that came in before today's presentation was tremors keep this person's son with young onset Parkinson's from getting a good night's sleep. Do you have any suggestions maybe for young onsets that might be different than someone who maybe have an onset later in life?
Well, I'm not a neurologist, so that's a little harder question for me to answer, but you know, I think it goes back to making sure that you have some medication that helps with their sleep period. Most people take medication to help their daytime symptoms, but there can be a wearing off effect, which could result in muscle rigidity, tremor, other things at night that can disturb their sleep. So usually using Parkinson's medication at night can be very helpful. Usually it's the long-acting medication, Cinnamate CR, or some variant of that, with or without some other medication.
Just had a question come in, Dr. Stein. Have you seen any improvement in sleep in patients that have deep brain stimulation therapy?
The answer is yes. So people that get subthalamic deep brain stimulation, the data, and I can't tell you how much data there is, but the data seems to suggest that they do get less autonomic dysfunction, less muscle rigidity, and they have better quality sleep. So, most of the things that we talked about with Parkinson's that can cause disruption in sleep actually are better with deep brain stimulation.
Dr. Stein, I have a question for you. Do you find yourself sometimes brought in to consult with as like a team member when somebody has Parkinson's, for instance, a patient, a neurologist or movement disorder specialist, and you kind of tackle the sleep issues someone might be having?
I've never been invited in the same room with a neurologist, so.
Do they call you though?
They do, but they usually don't do it because of sleep issues. They do it because of the accessory medical sleep problems or disorders. So if somebody has obstructive sleep apnea and Parkinson's, I'll see them for the obstructive sleep apnea, but I'll deal with some of the issues with Parkinson's disease. If they have REM behavior disorder, or if they have restless leg. So they usually bring me in because of the sleep disorder, not because of the Parkinson's disease, even though the Parkinson's disease is a sleep disorder.
Right, right. And a follow-up question, do you, for someone who has Parkinson's, maybe they haven't had a sleep study, is there any special kind of setup that would be required for somebody who has Parkinson's to participate in a sleep study? Would you make any kind of special accommodation?
No, there isn't. But again, it has to do with history, all right? The reason we usually do sleep study is determine if they have sleep apnea, but some sort of parasomnia, like REM behavior disorder, right? So it sort of depends on what your history is and what is the concern. If it's mostly muscle related, if it's mostly pain related, you don't need a sleep study for that. But if you're snoring and you're, have elevated blood pressures in the morning and your spouse says you stop breathing, or you throw your sheets all over the place, so there's clearly a lot of movement at night, you'd certainly be concerned about sleep apnea or some sort of kicking or like periodic limb movement disorder, which we didn't talk about, but it's another movement disorder. Or, if there's an acting out of dreams, which is what essentially happens with REM behavior disorder, then we would do sleep studies, probably with an extended montage, but a similar sleep study with maybe a little bit of additional recording.
We have one question that just popped up. Hold on just a second. Can hypnosis help with sleep? Have you had any experience?
Not with sleep disorders, but with insomnia sometimes. But not with, REM behavior disorder or sleep apnea, restless leg, or with Parkinson's, but with insomnia, things like mindfulness, which tries to get you to not focus on your problems, but try to come up with better defense mechanisms of how to deal with stress or manage stress better. Hypnosis can be helpful for certain things that get people anxious, upset, or so it's a way of maybe helping with some of their the problems that make it difficult for them to relax and go to sleep. So hypnosis has been used. I can't tell you that I've personally used it myself or anything, but it's mostly some way of helping with insomnia by calming people down and getting them into a better state of mind.
Well, that's all the questions, Dr. Stein. David, I'm going to
Hi.
turn it over to you.
Dr. Stein, I'd like to thank you very much for taking the time to join us today and for presenting a wealth of information in a manner that I'm fairly confident most people here were able to understand. Our goal in inviting you was to try and help people understand that there is an interrelationship between Parkinson's disease and sleep issues. Parkinson's being the very complicated disease that it is. I would remind everybody that if you've seen one person with Parkinson's, you've seen one person with Parkinson's. And while there's a tremendous wealth of information that Dr. Stein has shared with us today, it's important that you take questions that you have about your specific medical conditions and your specific Parkinson's treatments to your primary treating Parkinson's doctor, because they're the ones that are responsible for your health.
This Parkinson's Social Network program is made possible by the generous contributions from our donors. For more information, visit our website at parkinsonsocialnetwork.org. Thank you.